Our first speaker today is Dr. Emmett Ray. Dr. Ray is a neurologist at Aurora Medical Center in Kenosha, where he treats illness and injuries involving the brain and nervous system. He is a highly trained specialist with interests in epilepsy, stroke prevention and treatment, headaches, and memory disorders. Welcome, Dr. Ray.
Hi, am I on? Can you guys hear me?
Yep.
Okay, perfect. Thank you for that introduction, and I will add that I also enjoy treating Parkinson's because that is important to me. That's why I'm here. So, yeah. Thank you for having me over. This is the second time we have done something like this here. I'm excited to do this, and so thank you. And this is a different format, and all of us have to get used to it. I'm not used to presenting in front of video. I mean, in front of a computer. So, and I'm not being able to see the faces of my presentees and victims. So this is a different experience. So please bear with us and please bear with me while we get used to this mode. Quick question: How long do I have, and what is will the questions be at the end of my talk, or is it going to be at the end of this all three presentations?
It'll be at the end of your talk. You have about 20 minutes.
Perfect.
Or 20 minutes prior to the end of the hour.
Sounds good. Okay, if you can just sort of give me a warning close to it. Okay, so I'm going to talk about, my talk is going to be about the early signs and symptoms, actually, and most of the signs and symptoms of Parkinson's. And I know my colleagues, Dr. Finseth and Dr. Swanson, will be talking more about the therapeutics of Parkinson's. So I'll jump straight in. So the outline of my talk is going to be we're going to talk about a brief background of Parkinson's disease, followed by the clinical features, including the predominant motor symptoms, but also the extremely important and often very more concerning non-motor symptoms. And then we'll take questions at the end. Okay, so jumping right in. So Parkinson's disease was first described by James Parkinson in 1817. It is the second most common age-related neurodegenerative disease after Alzheimer's being the most common. It is the second most common. Prevalence, as everybody knows, increases with age. The prevalence in the United States is 1,900 people per 100,000 in 80 and older, but 5% of the patients are diagnosed before their age 50. So it is not just a disease of older people. It occurs in younger people also, and it is extremely disabling. Amongst the most famous younger folk we know, Michael J. Fox is well known. It affects more than 10 million worldwide, 1 million in the US by 2020, 1.2 million by 2030. 60,000 new cases per year. So it's increasing and extremely common. 150,000 cases in Wisconsin. Predominantly affecting males, but I mean, I shouldn't say predominantly. It affects both males and females, but males are more affected. And there are unclear environmental and risk factors and lifestyle risk factors. Interestingly, cigarette smoking is thought to be protective, but that doesn't mean if you don't smoke, you go and start smoking cigarettes, because that's not worth it. There are significant other risks of smoking, where if you are a smoker, have been a smoker, there might be some protection that you have. Caffeine and peppers. There was some research about the pepper family, and tobacco is a member of the pepper family, so may decrease some risk. There were some reports, but no clear data. Pesticide exposure may increase risk. Nerve gas exposure there is well-known increased risk from that. All right, so when you call a neurologist, you will get some pathology and diagrams here. So what is Parkinson's disease and what is the mechanism of Parkinson's disease? Why is it there? So it's a lack of dopamine, a chemical substance called dopamine, which is responsible for modulating our movements, that is reduced in the brains of people with Parkinson's. And I'll just try and do something here. I'm not sure if it'll work, but my wife taught me how to do this. I'm going to try and see if I can get this to work. So let's see here. So, yep. All right. So there is a loss of dopamine producing neurons in this area of the brain, which is the midbrain, which is the back portion of the deep portion of the brain. This is one area called the substantia nigra, and then there is an area below that called the locus ceruleus. Again, we don't need to just go too deep into this, but this is where the dopamine is produced, and it is lost in. There is a paucity or decrease in the neurons producing dopamine, and those neurons project to the basal ganglia, which is where the movements are modulated. So that's the basic mechanism of Parkinson's. And then there is this body called Lewy body, which accumulates in the brains, which is a misfolded protein called alpha-synuclein. I promise there won't be too much more of this, and of course. The next slide. Okay, here we go. So this is a brain of a patient with Parkinson's disease on the left and a normal brain on the right. So this is the locus ceruleus, which is, you see it nicely dark in the normal brain, but kind of less dark in the brain of Parkinson's patient. And that is pretty classic because of lack of dopamine producing neurons. And here is the alpha Lewy body, which has the deposition of this protein called alpha-synuclein. Okay. All right. So going into the symptoms, there are motor manifestations like I discussed at the beginning, and non-motor manifestations. So Parkinson's essentially used to be known as a disease of motor manifestation. That's how, when we were training as residents, we were taught about Parkinson's, and those were initially the best known features or the best described features of Parkinson's. Increasingly, we have come to know about non-motor manifestations also. So we'll just talk about the motor features. The cardinal motor features are three. There's a triad in Parkinson's. The first is bradykinesia, which must be present in all patients with Parkinson's to confirm a diagnosis. Bradykinesia is a slowness of movement. Brady is slow and kinesia is movement. So bradykinesia is a slowness of movement or difficulty with movement, which as people with Parkinson's know or their caregivers know is a cardinal feature. In addition, there may be rigidity or stiffness, and tremor, which is the most commonly described symptom or recognized symptom of Parkinson's, but it does not need to happen. It does not need to be there in Parkinson's. Bradykinesia has to be there, and out of rigidity and tremor, at least one of those should be there to suggest a diagnosis of Parkinson's. Additionally, postural instability is an important feature. Some people recognize it as a cardinal feature, and some people could put it in the additional motor features. So we'll talk about all of these in the next couple of slides. Stooped or bent posture, freezing, dystonia, and I can talk about that, and we'll probably be talking about that in the next couple of slides. So bradykinesia, or paucity of movement, or slowness of movement, this is a cardinal feature and must be present to make the diagnosis of Parkinson's. And how it is manifested as difficulty with initiating movements. So say, for instance, you're getting up, it's hard to get up from a sitting position. Once you get up, it's hard to start movement. And then there is decreased automatic movement. So things like swinging your arms, that is decreased. This comes naturally. It is an automatic movement to most of us when we walk, but not so in somebody with Parkinson's. That movement is decreased. It is manifest as decreased arm swing. So that is a manifestation of bradykinesia. Decreased blinking, decreased or paucity of facial expressions, as all caregivers of Parkinson's and patients with Parkinson's know, and their families, that patients with Parkinson's will have this blank expression, decreased blinking of the eyes, relatively emotionless facial expression. In fact, that is one of the questions I asked most of my patients and their families. Have you noticed a decreased facial expression or a change in facial expression of your loved one? And most of them would say yes. Increased stillness. So bradykinesia is a cardinal feature, has to be present. Tremor, like I said, it is the most recognized feature. It is one of the features which may be present, and it is very common. It is common in 80%, but does not have to be there. It is typically seen in the hands, but can also be seen in the legs. Typical Parkinson's tremor will be more on one side versus the other in idiopathic, what we call the idiopathic or most common variety of Parkinson's disease. It is asymmetric at onset, and even later in the condition, unless it goes to the very advanced stages, it might be more on one side or the other. It is a resting tremor. So if patients may, if you go on to hold a cup or something, you may not have a tremor. But if you're sitting at rest watching TV or reading a book, your family may notice you to have a tremor. When you're walking, like I said, there could be decreased arm swing, but there could be a tremor in the hands. And the tremor is classically described as a pill rolling tremor. And we'll see that in a couple of videos. And so it is like this is the character of the Parkinson's tremor. It's important, like I said, I'm going to reiterate, but it does not have to be present. Rigidity or stiffness or increased tone. Again, it's an important feature. It's a common feature which we search for, but it does not have to be present. It is most common in the arms and legs, but also may be present in other areas like the face, and leading again to decreased facial expression. The neurologist is looking for this. So when they ask, when I examine patients, I will sort of hold their hands and try and move their wrists and see if there is any stiffness. And it is classically described as cog wheeling. So there will be a ratchety sensation, which I will feel, which tells me that, hey, listen, I should look for this. I'm seeing stiffness, which is suggestive of Parkinson's, and I should be looking for that. So it is important. It is disabling. Stiffness is disabling. This is one of the more disabling features. So among the more disabling motor features are the rigidity or stiffness and bradykinesia, because those are really impact. The tremors, yes, over time they will become disabling, but not as disabling as the rigidity and bradykinesia. And coming to the additional motor features, they include postural instability, and let's talk about that. So posture in Parkinson's. As patients of Parkinson's, and more importantly, the caregivers will know, patients with Parkinson's have a stoop classic posture. Over time, they develop a stoop posture. And this is because of loss of automatic controls. Patients with Parkinson's do not have the same controls which somebody who does not have Parkinson's will have. So like most of us will, like I said, swing our arms when we walk. Patients with Parkinson's are not able to swing their arms. Patients with Parkinson's are not able to walk at the same time and lift up their head at the same time. They can do one or the other. So what is normal automatic movements for somebody who does not have Parkinson's is an effort for somebody who has Parkinson's, and becomes extremely hard for them. So that's why they have a stoop posture. The other reason for stoop posture is the muscle stiffness. They just are unable to raise their head up. Sometimes with advanced Parkinson's, as people and their caregivers will know, at medication, oftentimes they may develop a stoop posture, concentrating on another activity. So again, loss of the automatic control. Things which come automatically to others may not come to automatically to patients with Parkinson's. So unless they're told to look up, they may not be able to do it if they're concentrating on the walking and be safe while walking. If they've been in one position for too long, that might also result in postural stoop posture. So Gait examination is an important part of Parkinson's disease examination, and most neurologists, if not all, will ask you to walk to check on your gait to see if you have symptoms of Parkinson's. And the other test we do is the pull test, which we do to check if you do have Parkinson's. So we would pull you and check if you're able to resist the pull or if you fall over in a stiff way. And I think I do have a video of that, and we can share that in the next few slides. Limb dystonia, which is not very well recognized, but is manifest as cramping, mostly seen in young onset Parkinson's, typically in the feet. Sometimes there may be cramping or curling of the feet, and it is painful. It is an early symptom and often in the morning. So I'm going to stop talking here and just show a video, which will illustrate most of the features, and let me know if you can't hear sounds and things, please let me know.
People with Parkinson's disease are diagnosed with the condition based on finding 3 out of 4 major features. The one that most people know about is the tremor.
Parkinson's, oh, that's that shaky disease.
People with Parkinson's disease usually have a tremor, but not everyone with Parkinson's does. The tremor is called a resting tremor because it occurs at rest. Most patients have it in their fingers or their hands. Other parts of the body may tremor as well. Parkinson's tremor frequently affects the jaw. It may affect the feet. It's very uncommon to affect the head, however. People who have a head tremor usually don't have Parkinson's.
And over time, I started getting tremors, especially my left hand started first, and now I'm pretty much bilateral with my tremors. And my left side was much weaker than my right side. I also was fatigued an awful lot. And over time, I also started having difficulty speaking. I started stuttering and mispronouncing words, and that's never happened to me before. So it was kind of a shock.
A second feature is slowness of movement. People with Parkinson's disease have 2 issues related to slowness. One is called Bradykinesia. Brady means slow. Kinesia means movement, so slow movements. And akinesia, or absence of movements. We look for slowness, and we do this by having the patient tap their fingers, open and close their hand, do rapid alternating movements, and we score these so that we can keep track of how the patient is either improving or declining or keeping stable from visit to visit. We also check legs for slowness by having them tap their heel up and down. We check ability to walk. One test is to ask the patient to stand up without using their arms if they can. We watch them walk. We look at their posture. We look at how long their stride is from one step to the next, what their arm swing is like, how they turn. And then we check their balance by pulling them backwards. People with Parkinson's disease tend to move less than other people. They tend to sit in one place like a statue and not to move. As a result of that, many Parkinson patients have a stare. They don't blink as much as other people. And sometimes they might have even a bit of drooling because they don't swallow as much as other people. Whereas most people think of Parkinson's disease as being a tremor disorder and that tremor causes a lot of problems. In fact, tremor doesn't usually cause many problems, but slowness does. All of these sorts of things that we take for granted and that we do without thinking about, Parkinson patients frequently have to think about and consciously plan how they're going to put on their shirt, how they're going to button. And as a result of this problem, it takes a very long time and allows them to do far fewer things in a normal day than other people do. A third feature of Parkinson's disease is something we call rigidity. I don't know if you can see, but it's a little slower in the elbow because there is some resistance to movement and a little bit in the wrist as well. So with what we call cogwheeling, there's a little ratchety type of sensation. Parkinson patients generally are stiff. Very often, especially in older people, they initially blame this on arthritis. The patients may or may not feel stiff, but the doctor can feel the stiffness when they move the limbs. It can be in the neck, in the elbows, the wrists, the knees, the ankles, any place. And the fourth feature has to do with walking and posture. Parkinson patients tend to be stooped. When they walk, they tend to be slower. They don't swing their arms. Sometimes when they walk, as the disease progresses, instead of having their heel strike the ground first, they walk on flat feet, which slows them down. When they turn, they may require several steps. Some other features that are very common in Parkinson's disease but aren't required for making the diagnosis are micrographia, which means small handwriting. People with Parkinson's disease tend to write small. The interesting thing about this is that the patients are fully aware of it. And while you think that if somebody is aware that their handwriting has gotten smaller, they can simply write larger, one of the big problems with Parkinson's that causes them to be slow is that they have difficulty doing two things at the same time. So if they concentrate on writing large, they have difficulty thinking about exactly what it is they want to write. And if they think about what they're writing, then they write small.
My writing is still very small. I can write normal size if I think about it, but I have to be thinking about it. If I'm just writing a note to somebody or message to myself and not thinking about it, it's very small. And then I see it later and say, oh, it's very small.
Another feature that's common in Parkinson's disease is an overactive bladder.
So good to see some other faces other than just mine. So, and I think a video illustrates things much better. A couple of things. The micrographia is an important feature. That's why we often get paid. I ask patients if their writing has changed, not just become more erratic, which can happen with any kind of tremors, but the writing becomes smaller, and often we would get a demonstration writing sample. The other thing is, which I did not mention in the posture and gait, and the stoop posture, the decreased arm swing, the slow movements, the shuffling gait, the taking very short steps, difficulty with initiation of movements, and then difficulty with stopping once the movement is initiated, and then reinitiation of movements. So say, for instance, they have a difficulty with starting the movement, and then if you try to stop them, they can sort of keel over. And then once they stop, it is difficult to restart the movement. And then there is difficulty with initiating turns, and patients may require many small steps before they can accomplish finishing that turn. All right. So those were the cardinal features. As the Parkinson's disease gets advanced, things like Dyskinesias happen, which are abnormal motor movements. Wearing off of the medication can happen earlier than typically. There can be unpredictable off times as well as a failure of an on response. That means that suddenly the medication may wear off and the patient may be left with significant bradykinesia and rigidity, or the medication may not even work once the medication is taken. Gait, there may be freezing of gait, and akinesia, which is just an inability to move. And I know Dr. Vincent will be talking about these in more detail when he talks about the medication strategies in Parkinson's. So I'm going to skip this. So just stages. There are 5 stages traditionally. One is the first is the mild stage, where the symptoms do not interfere with activities of daily living, and basically patients will have a tremor typically on one side of the body, and goes on through a continuum until stage 5 can be wheelchair bound and bedridden. But most patients initially, when we see them, are in stage 1 or 2. Second stage is that symptoms are bilateral, does affect some of the activities of daily living, but still able to live independently. Third stage, there is postural instability, slowness of gait, able to live independently, but requiring assistance. Stage 4 is a little bit worse than that, and requiring much more assistance and inability to live alone and needing assistance with all activities. All right, so those were the motor manifestations. I'm just going to touch through the non-motor manifestations, which are also fairly disabling. So some of these include loss of smell, sleep disturbances, constipation, autonomic dysfunction, fatigue, pain, depression, anxiety, huge, dementia, hallucinations. So I'm going to touch through some of these, but not through all of these. Autonomic disturbances are extremely common in Parkinson's. There are certain types of Parkinson's which are especially prone to having autonomic disturbances, the so-called Parkinson's plus syndromes, or what's also called multi-systems atrophy or Scheidegger syndrome. Basically, there is instability of the autonomic nervous system, which is responsible for regulating blood pressure. So patients may have lightheadedness when they stand because the blood pressure autoregulation stops. So the blood, normally when we stand, the reaction of the body is to pump the blood to the brain. But in patients with Parkinson's, this is who have autonomic dysfunction, this autoregulation may be disturbed and their blood may not go to the brain. So they may either feel lightheaded when they stand, or if it is severe, they may pass out. It is fairly common. And like I said, it is due to dysfunction of the autonomic nervous system. Sometimes the dopamine, the levodopa, may also itself cause this to happen. So if this happens after levodopa, we do encourage sometimes that patients should lay down if they feel dizzy after taking the levodopa. How we try to sort of circumvent this: increased water fluid intake, no skipping meals, eat regular meals, increase salt intake, getting up slowly from sitting or lying positions, take regular meals, but don't take a huge big meal. Compression stockings may help, and all of that. We may need to discontinue antihypertensives or sort of paradoxically give drugs which actually elevate the blood pressure, like there are drugs like midodrine and fludrocortisone, which can actually elevate the blood pressure so as to increase the blood flow to the brain when we stand. Cognitive impairment. I do want to stay here for a little bit. It is extremely common. Up to 70 to 80% of patients will develop cognitive impairment. Initially, it might be subtle, but later may be much more severe. It is what we call subcortical. So there is a decrease of processing speed, slow thought, trouble recalling memories, impaired attention, visual processing, trouble with planning. So patients with Parkinson will tell you they know what they want to do, but they have to plan ahead and plan to execute the execution of the tasks that they plan is hard. Initially, the changes are in the basal ganglia, but later there may be dysfunction of the higher brain cortical structures. How to avoid it? Exercise is huge, and Dr. Finseth will also be talking about that. Exercise helps in improving mood in Parkinson's, improving motor symptoms, improving cognitive symptoms. That is the one modality which has been shown to benefit all Parkinson's symptoms. Exercise, remain cognitively active, keep interacting, keep social interactions alive. I know that's hard in this era of COVID, but we need to do the best we can to continue to keep mentally and physically active, take up challenges, new challenges, skills which you don't know, say for instance, learning a new language or learning a new instrument, or things which you're not comfortable with may help in the cognitive dysfunction. In most cognitive cases of cognitive dysfunction, including Parkinson's. Healthy diet, low-fat diet will help low-fat, avoiding processed foods, avoiding excessive salt intake, all of those will help. Controlling blood pressure, cholesterol, and diabetes, and avoiding certain medications which we sometimes use in patients with Parkinson's, like anticholinergic medications and some of the antidepressants also may cause cognitive impairment. So we have to be careful and balance our use of those. And optimize dopaminergic therapy also early on. And then increasingly, we are giving more levodopa early on in the condition as opposed to reserving it later on, because it helps with the movement, it helps with mood, it helps with cognitive impairment. So, and I know Dr. Finseth is going to talk about this. So there's a continuum of changes. Initially begins with slowness of thought and then progresses through what we call mild cognitive impairment to dementia. Again, Parkinson's related dementia is an entity of its own. There are other conditions which might affect patients with Parkinson's, including Alzheimer's disease, as well as strokes causing vascular dementia. But Parkinson's related dementia is recognized as a things that can be done to sort of minimize the this, not the condition, but the effects of this condition. Do one thing at a time with the patient. Don't show and tell at the same time. Get the patient's attention before asking a question. And try and maintain their attention and just make sure that they are processing it. So keep sort of cueing and re-cueing again and again. Eye contact, simple language, give choices like, do you want to do this or do you want to do that, as opposed to what do you want to do? Speak slowly and clearly. Socialize in smaller groups and be patient. That's important. Pill boxes and alarms may help so that you can remember medications. Do one thing at a time. Don't try to multitask because, like I said, automatic things which come automatically are hard. So try to do one thing at a time. Decluttering, which might be good for all of us anyway. Keep track of the calendar and current events, making lists, having a regular routine. Interactions, social interactions are super important, and we do the best we can with that. Addressing safety issues, say for instance, make sure the home environment is safe, carpeting, etc. should be safe, because falls can happen and will happen in patients with Parkinson's. Planning and finding resources, and the WPA is a fantastic resource. All right, touching on visual hallucinations, which is extremely disruptive and may happen in up to 40% of patients. It is, and it can actually be worsened with Parkinson's medications, especially the dopamine agonists, the ropinirole. It can become more vivid and threatening and severe. And there is an entity called Lewy Body dementia in Parkinson's, which is classically characterized by visual hallucinations, and it is extremely disabling, and it's hard to manage. So what we try to do is we eliminate and reduce medications that can worsen these hallucinations, like some of these medications which we use for dementia and Alzheimer's, like donepezil and rivastigmine, which are used in patients with Alzheimer's, but may have problems when used in patients with Parkinson's. Sometimes we would give drugs like quetiapine and pimavanserin and clozapine, which do reduce the visual hallucinations. The dementia drugs are interesting because sometimes we use them to help with the cognition, and sometimes we have to discontinue them if they impair cognition. So it is complicated, the relationship. So we have to balance out things. Depression, extremely common. More than 50% patients will have depression. It's not just because of the motor disabilities, etc. It is a lack of dopamine itself will cause depression. So it is extremely disabling, and we have to keep a sort of high index of suspicion because it is going to happen for 50% of patients. Exercise, seeing a therapist, and using antidepressant medications, especially the SSRIs, may help with them. Anxiety, again, extremely common, and relaxation techniques and medications if needed. Insomnia. All right. So sleep disturbances are extremely common in Parkinson's. It might be sleep onset insomnia, that is difficulty in initiating sleep or falling asleep, or sleep maintenance insomnia, or that is difficulty with staying asleep. Happens in up to 80% of patients with Parkinson's. And patients may have, it might be because of motor symptoms like stiffness or pain, or need to use the bathroom, because bladder spasms can happen commonly in Parkinson's. Sleep-centered dysregulation, drug side effects, all of these can cause sleep disturbances. How to sort of manage it? Have a regular schedule, make sure not watching TVs or screens at night. Make sure that you remove any medications which might have insomnia as a side effect. We can use drugs like melatonin and trazodone to help with that. We try to avoid the benzodiazepines because they can have other side effects in patients with Parkinson's. So we try to manage this, but it is extremely common having some sleep disturbances in Parkinson's. Then often it's an early symptom, even oftentimes before the motor manifestations start. Like we said, regular sleep hours, regular exercise, but exercise in the morning and not later in the day. So because exercise itself might inhibit sleep. Avoid excessive daytime napping, relaxing bedtime routines, say, like avoiding TV and screens, maybe having shower in the evening before sleep, or reading, or avoiding alcohol and largely. Okay, REM sleep behavior disorder, up to 50% of cases, patients may have it. Apart from the insomnia, and this is the other common sleep disturbance which is seen in patients with Parkinson's. Families will tell us that patients with Parkinson's often talk excessively, or have motor movements and shift around, or sometimes in severe cases, they may even box out or act out their dreams and screaming and thrashing. So this is, sometimes they may fall out of bed and injure themselves or hit the partner. So, and again, this also may precede Parkinson's disease. So what do? We just have to work around to manage these. So bed safety measures, remove any sharp objects, remove the spouse from the proximity to the patient, because there have been instances when the spouses have been significantly injured because of this behavior disorder. Drugs which can be used, SSRIs and melatonin, that is our first line of treatment. And discontinue the SSRIs like the antidepressants, giving melatonin. And sometimes we do give clonazepam to give so that we can avoid this from happening. So this is quite disabling. The other thing we want to make sure is that sleep apnea, patient does not have sleep apnea, which is causing this to happen. So, so this is something to keep in mind. Fatigue. I'm just going to rush through the remainder of the slides. Fatigue, which is common in Parkinson's, described as lack of energy, extreme tiredness, multiple causes for it, the bradykinesia, medications, depression, all of these can cause fatigue. It's important to rule out any other medical causes of fatigue. Exercise is important, and that will help prevent fatigue. Exercise in the morning, naps at getting adequate amounts of sleep would be important. Sometimes it may be a manifestation of lack of enough dopamine in the body. So we might need to optimize the therapy or try other agents, which like amantadine or sometimes even Ritalin to improve the fatigue. Bladder dysfunction, so urinary urgency, so need to use the bathroom multiple times, sometimes incontinence. And this is problematic because patients with Parkinson's have difficulty walking. So if they have to rush to use the bathroom, couple that with difficulty walking, that is a prescription for falls. So this can be extremely problematic. So things to manage: avoid caffeine, minimize liquid ingestion prior to bedtime. Sometimes rehabilitation, physical therapy might help with strengthening of the pelvic floor to prevent this from happening. medications like antispasmodic medications, but you have to be careful with them because they themselves can impair memory. Sometimes Botox injections may need to be administered. Drooling, because of reduced swallowing, can happen and is an important disabling feature with patients, causing significant distress to patients with Parkinson. And things like glycopyrrolate medications can be given. Botox injections can be done also. Sexual dysfunction is common, seen in 50% of cases. And then things for men, things like Viagra can be used, and hormone replacement therapy can be used. Excessive sweating, fairly common. We again, maybe a manifestation of decreased dopamine and which might need to be optimized, or Botox can be used to areas of swallowing problems, typically late in the condition, difficulty with swallowing pills or coughing or choking. And we may need to do a swallow evaluation for that and make sure things are going in the appropriate passage as opposed to pneumonia. Speech therapy will be important for that. And in advanced cases, feeding tube may be needed. So constipation, important. Important feature, early feature, disabling feature of Parkinson's, and very common. So again, things to prevent it are increased fiber, exercise, and hydration. And medications can be used like Metamucil and Miralax, etc., can be used. Loss of smell, again, fairly common, and an early feature of Parkinson's. Hence, they may recognize diminished taste as well. And 90% of cases will have it.
Hey, Dr. Ray, it's Jeremy. I'm going to jump in right now and just ask a couple questions so we stay on schedule. If you want to stop screen sharing, right now you're just a really small blip on the screen and nobody can see you. So if you want to stop that,
Thanks.
perfect. So first of all, thank you for the presentation. I know we cut you off a little soon. The presentations will be available on our website, so if people want to look at the slides we missed, they can definitely do that. But like I said, in the interest of time, we want to try and just get a couple questions in before we go to break. You covered a lot of different issues with Parkinson's disease, movement disorders, and then the non-movement issues. Two questions I really have that have come up a lot lately is with, Gary talked a lot about the current pandemic and people being home alone. What are you seeing within the practice with people who are having some functional decline, and what are the things you're recommending for them to do to keep active for not only their health, but their Parkinson's disease and their mental health as well?
Yeah, it's been challenging, that to say the least, for all our patients, and especially our patients with Parkinson's. So we are, patients, families are trying to avoid, the relatives and children are trying to avoid meeting their families so that to avoid exposure to this contagious disease. So that has led to a significantly decreased social interaction in all elderly population, that is especially complicated in our patients with Parkinson's. So we are seeing that, and that leading to cognitive decline, increased depression, all of this. So and then lack of support groups. The support groups have also reduced. So the meetings, so I think we just have to. It's hard, I can tell you, but increasing the interaction, whether it be virtual or trying to maintain a select bubble of people, maintaining your bubble, as in have patients who have other folk who sort of maintain the same level of distancing with as you, and interact with a select bubble of patients, of people, not patients, people, and would all be helpful. But I can tell you, it's been challenging. And again, optimizing, if therapy is needed, trying therapy or antidepressants, because we are seeing this more and more, and especially over the past 6 months. I don't know if that answers your question, but it is, there is no easy answer, is what I can tell you.
I think it answers it because one of the things I keep hearing is I've had a few friends who tell me that's my COVID family, because it's COVID. That family down the street is the one we hang out with. We know where they go. we kind of have similar networks. We know that we're both negative, so it's a little safer for us. And I think that's kind of what you're talking about, is having that bubble of friends. And I think that kind of goes into what the next question is, was how to deal with isolation. I think that's the other part we're hearing from is, while we're doing these video programs and virtual programs, and it's great, and we're providing education and resources, you're still sitting at home isolated. So what are, and I think you touched on a little bit, but any other things you would recommend to people who are dealing with isolation, and how they can maybe address that to help themselves be more engaged and help with their health in a lot of ways?
Yeah, this is a big problem. And again, we have noticed it affecting both age extremes, kids and the elderly population. I mean, we are seeing patients and doing stuff, still going on, doing our stuff. So we have that social interaction, and social interaction is super important. I mean, the virtual world cannot replace the social interactions. I don't have great things, but things that you can do on your own. Say, for instance, online, learning a new skill, a new language, a new trade. There are resources. Granted, it's sometimes hard to access and navigate technology, but try and make it your friend. Maybe learn technology. I honestly, I don't have a great answer for these things, but all of us are trying our best to figure out these answers for ourselves as well as for our patients. But again, it is super important, and the virtual world cannot replace the physical interaction. It's our social being, and this is a big problem.
Well, I think you hit it on the head right there.
With the balance, of course, we don't want a patient with Parkinson's to be getting COVID if we can try. I mean, we should definitely try and avoid them from getting exposed to COVID, because that will lead to its own set of challenges.
Absolutely. And I think what I was going to say, you hit it on the head. We're all trying to figure it out. Every person, young to old, everywhere in between. But it's also individual for everybody. That what I do to fight off isolation may not work for the next person. So it's kind of finding what your thing is and doing that to the best of your ability. So with that, I just want to thank you so much for your time. I think if you listen closely, you can hear a round of applause coming all the way down to your home down there. So we appreciate that.